Welcome to RAAONLINE. So today we are going to deal a very important topic, the pelvic inflammatory disease, otherwise called as PID. Okay. So woman coming to you with a lower abdominal pain, and your most possible diagnosis is going to be a UTI, and you are doing a urine routine examination. In your urine routine, you are seeing plenty of puzzles, right? It's one of the most common phenomena, right? So you coin the patient as UTI, and you start sending cultures and some antibiotics, and you discharge the patient, right? The understanding about pus in urine is totally different. Okay, any inflammatory pathology in and around the urinary bladder can cause pus in the urine, understand? And appendicitis, a peritonitis, or any inflammation in the adjacent structures can also produce pus in the urine. Okay, so because you have seen a pus in urine doesn't mean the patient is suffering from a urinary infection, right? So this is how most of the pelvic inflammatory disease are missed in your ER. Okay, so you need to have a very thorough understanding about PID, because this is one of the reason for not only ovarian tumor but also infertility and even high mortality if it develops into tubo-ovarian abscess. Okay, so today we are going to see in depth about pelvic inflammatory disease. So this comprises a spectrum of infections of female upper reproductive tract. Okay, this is very common, and possibly you will be missing out in your ER because of the reasons I said you, and it's also a serious disease. Okay, it's initiated by an ascending infection from the vagina or the cervix. Okay, so this PID includes salpingitis, endometritis, myometritis, parametritis, oophorytis, tubo-ovarian abscess, and not only that, this particular inflammation can extend to other structures as well, okay, like periappendicitis, pelvic peritonitis, or even diffuse peritonitis, or sometimes it can involve the hepatic capsule producing hepatitis. It's called as a perihepatitis, which we call it as Fitz-Hugh-Curtis syndrome. Okay, this is an MCQ for you, dear friends. So why should we learn about this? See, if you keep treating the patient as UTI, then next time you'll coin the patient as a recurrent UTI, right? So it will be treated very partially. And understand the significance of diagnosing this is that if you miss it, then the patient will end up into long-term sequelae. That is tubal factor infertility, implantation failure after in vitro fertilization, ectopic pregnancy, or chronic pain. Okay, understand around 11% of reproductive aged women suffer from this kind of issues. Okay, so all the sequelae which I mentioned are very serious issues, right? It is not like 1 day of hospital admission or 2 day of hospital admission. The infertility factor, implantation failure factor, ectopic pregnancy, chronic pain, all these things are very serious and significant. So as an emergency physician, you need to understand the pus in urine is not just UTI. It can be because of any inflammatory pathology in and around the bladder, which can be even PID. So remember, the most common cause of death in PID is because of a consequence of PID. There is a rupture of tubo-ovarian abscess. Okay, the mortality is 1 in 10, that is 10%. 1 in 10 will die. Okay, even with current level of advanced treatments. Okay, now coming to the pathophysiology, let's start with the organisms involved. When speaking about PID, the organism by default is Neisseria gonorrhea and Chlamydia trichomaticus. Okay, so if someone asks you what is the most common organism, you can name 3 different groups of organisms. One is the Neisseria gonorrhea, second is the Chlamydia trichomaticus, and third is the bacterial vaginosis associated organisms. Okay, so this Chlamydia has developed various measures. It has developed various genes to reflect away the autoimmune system, the immune system of the body, so that it stores itself into the epithelial cells of the female tract. Okay. So coming to the bacterial vaginosis, the microorganisms involved are Gardnerella vaginalis, Mycoplasma hominis, and Ureaplasma urolithecum, and pigmented or non-pigmented anaerobic gram-negative bugs. Okay. So now homework for you. So what are pigmented or non-pigmented anaerobic gram-negative organisms, and what is the drug of choice? Okay, will you do the homework for me? I know you will not do the homework. So I'll tell you the answer. So pigmented meaning these are Prevotella, Porphyromonas, and the best coverage will be metronidazole. For non-pigmented like Bacteroid fragilis and Fusobacterium, here clindamycin works better. So for some patients, you will see your consultants writing both metronidazole and clindamycin. You might question that both are covering anaerobic bacteria, right? But even in anaerobes, there are pigmented and non-pigmented. For pigmented, metronidazole works better. For non-pigmented, clindamycin works better. Okay. Apart from the Neisseria and apart from the chlamydia and the bacterial vaginosis associated bugs, sexually transmitted Mycoplasma genitalium is also very common. It causes cervicitis and causes ascending diseases. Okay, and if the patient is infected by Trichomonas vaginalis, it has 4 times more association with acute endometritis. Moreover, viral infection like herpes simplex virus 2 affect the fallopian tube, causing inflammation, ulceration of the lower tract. Whenever say about ulceration, it means a disruption of the particular immune system, right? A mucosal barrier is a type of immune, right? So if there is an ulceration in the particular area, endocervical canal mucous barrier, then it aids in the translocation of microorganisms. And next, of course, human immunodeficiency virus 1, Candida, human papillomaviruses, all these things can be associated with PID. When coming to chronic PID, as far as India and India-like countries are concerned, like endemic areas are concerned, where tuberculosis is still the commonest etiology. So when dealing with chronic PID, you need to think about Mycoplasma tuberculosis, because still it's one of the major cause of tubal infertility. Okay, so schistosomiasis also causes PID and tubal infection, leading to infertility and chronic abortion. Okay, in patients who are using IUDs, exclusively they will contain actinomyces. Okay, so in your exam question, if the exam question is being like PID associated with IUD, the answer is actinomyces. Okay. So this is one box which you need to take a printout and stick it on your wall and see it on a daily basis to understand the organisms associated with PID. Okay. Sexually transmitted organisms, chlamydia trachomaticus and Neisseria gonorrhea, herpes simplex virus types 1 and 2, Trichomonas vaginalis, endogenous genital tract mycoplasma, that is Mycoplasma genitalium. Okay, doxy is resistant to it. Okay, so this particular bug is resistant to doxy. Mycoplasma hominis, Ureaplasma urolaticum. Anaerobic bacteria, Bacteroides species, Peptostreptococcus, Prevotella, Leptotrichia, and Atobobium and vaginae. Aerobic facultative bacteria like Gardnerella vaginalis, Haemophilus influenza, Streptococcus agalactiaceae, E. coli, which is very, very common, Actinomyces, and Campylobacter. So, the idea to be understood is that PID is basically an infection of the upper reproductive tract. Okay, so anything abnormal in the lower reproductive tract or any infection in the lower reproductive tract will affect the barrier. Thereby, it causes ascending infection from the lower tract to the upper tract. Okay, so basically, PID is an ascending infection. Okay, so although the cervical mucus serves as a functional barrier for this kind of ascending infection, this particular cervical mucus barrier is inhibited or broken down by various mechanisms. Number 1 is by enzymes produced by the bacterial vaginosis associated bacteria, basically. So these enzymes will degrade the particular mucus. Okay. Second, hormonal changes during menstruation and ovulation. During the early days of menstruation, menstrual cycle, and the later days of menstrual cycle, these are the two areas where the mucous membrane will be very, very thin. Okay. So hormonal changes can cause disruption of the mucous membrane, and retrograde menstruation can help in ascending infection. Okay. And next is intercourse. During intercourse, there will be rhythmic mechanical uterine contractions. Actually, this is a physiological phenomenon. This aids in the movement of sperms. Okay, this kind of rhythmic mechanical uterine contraction creates a negative pressure inside the uterus, which helps the sperms to move into the uterus, right? So along with the sperms, this infection also ascends. Okay, so such kind of ascending infection usually is limited to the endometrium. Okay, but if the patient is a gravid uterus, if the patient is in a postpartum uterus, then it could be more severe and more invasive as well. Okay, so if by chance this particular ascending infection gets access to the tubal area, okay, even then the tubal infection is limited at the mucosal layer itself. But if at all the inflammation is going to be very severe, then this inflammation will go through and through all the layers of the tube. Okay, it's called as a complement mediated transmural inflammation, and this usually happens with repeated infections. Okay, so you have the female genital tract, Okay, you have the uterus. Okay, if there is a lower reproductive tract infection, the mucosal barrier is lost, right? And because of activities along with the sperms, there will be ascending infection of the bacteria, usually affects the endometrium only, but in case of gravid or postpartum uterus, it can be more severe. And if at all the patient is immunosuppressed, if this bacteria gain access to the tubes, it affects only the mucosal layer. But if it's going to be a recurrent infection or an immunocompromised patients, this inflammation can be through the walls of the tubes, causing severe inflammation. Sometimes this inflammation can pour outside with pus in the pelvic cavity and spread through the peritoneum as well. Okay. So inflammation may extend to uninfected parametrial structures, including the appendix, ovary, the bowels. Okay. So infection may spread by direct extension of the pus from the fallopian tubes or through the lymphatics. Okay, it can go as high as up to the hepatic capsule. So this kind of either direct spread or through the lymphatic spread to the hepatic capsule causes perihepatitis, otherwise called as Fitz-Hugh-Curtis syndrome. Okay, it can also produce acute peritonitis, presenting as guarding and rigidity. So basically, now we know around 11% of reproductive age group women suffer from this kind of pelvic inflammatory disease, and usually in ER we miss out telling this is going to be UTI, right? And we know what are the organisms causing this, what are the mechanism by which PID is produced, and if the inflammation is too severe, the pus or the lymphatic route spreads this infection and inflammation throughout the abdomen, causing as high as the hepatitis level as well, right? There are chronic sequelae and acute sequelae for the PID. For that is one reason we need to identify and control it. Now it is time to identify the risk factors associated for PID. One is IUD, intrauterine devices. Okay, the first 21 days after insertion of IUD is very critical. Okay, that is when the highest risk is there. Okay, otherwise also if there is an IUD placed at any point of time, you need to suspect a PID. Okay, but the severity is very more in the first 21 days. The chances of getting an PID in an IUD patient is very high in the first 21 days. Okay, you can ask me how come an IUD causes PID. If an IUD is causing pelvic inflammatory disease, then why should we place IUD at all? It should be banned, right? So the understanding is this: IUD by itself will not cause infection. IUD by itself will not cause inflammatory changes. Okay, the patient would have had a sexually transmitted disease. By inserting an IUD, you would have helped that particular organism ascend up. Okay, whenever an IUD is placed, a small thread is left over the cervical orifice, right? So through that, this kind of infections can ascend very easily. Okay, so it is not the IUD that is the problem. You have placed the IUD in a patient who was already suffering from an occult STD. Okay, so in a patient with IUD, when you're planning to place an IUD, if there is an STD, that causes an ascending infection producing PID. So if you are planning to insert an IUD for your patient, check, screen for all the STD, sexually transmitted diseases. Only if found to be negative, insert an IUD. If it found positive, treat it and then insert an IUD. Okay, so per se, IUD does not cause us PID. Got it? And negative risk factors or like beneficial factors is that pregnancy decreases the risk of PID. Okay, because of the thickness of the mucous membrane, the mucus plug in the cervical os. But of course, even if I say pregnancy is relatively a less or decreased risk factor, but the first trimester of pregnancy is relatively a more riskier. Okay, patients can have fetal loss, patients can have even preterm delivery as well. Okay, so risk factors associated with PID are multiple sexual partners, history of sexual transmitted infection or pelvic inflammatory disease previously, history of sexual abuse, frequent vaginal dodging, intrauterine device insertion within previous month meaning within 21 days I mean, adolescence, younger adulthood, lower socioeconomic status and post-abortion. Okay, why specifically adolescence and younger adulthood is mentioned is that they feel hesitant to tell that particular complaint even to their parents, right? So they strongly feel it's going to be an UTI. And if by chance it's going to be a sexually related disease, it has a social stigmata. They will not let the parents know about that sexual activity on the first place, right? If at all a patient, a young girl who is unmarried, comes to you with a PID, if it's turned to be a sexually transmitted diseases, then that particular female will be hesitant to reveal her sexual connection or sexual relationship with, to their parents, right? So because of that hesitation, there are multiple adolescent age group women or people, patients who are actually suffering with the chronic diseases. What are the complications of PID? As I told you, the tubo-ovarian abscess, which occurs in 1/3 of PID. Infection and inflammation can lead to loss of ciliated epithelial cells in the fallopian tubes, which leads to scarring and adhesions, causing obstruction within the tubal lumens itself. It also causes ectopic pregnancy, tubal factor infertility, which is around to 50% of women with the recurrence of PID. With the previous history of PID, the tubal factor infertility can go as high as 50%. Okay, and you need to worry about the sequel of PID, that is the recurrence of PID, chronic pain, menstrual disturbances, chronic dyspareunia. This all can affect quality of life. Okay. So recurrence of PID may occur because of, number one, inadequately treated infection. Very common. You think it is UTI, you treat it with some 5 days of antibiotics and leave the patient without any follow-up, and you don't know whether the patient is improving or not. So it turns to be inadequately treated infection. And you may treat the patient but not the partner, right? Non-treatment of partner or partners, okay? And you may treat the patient and the partner, but there could be reinfection from another sexual contact, right? So these to be monitored if at all your patient is coming again and again for the same complaint, okay? Understand, PID has increased risk of ovarian tumors itself. So now clinical features. So you receive a patient complaining of bilateral lower abdominal dull or crampy pain, and that particular pain is increased by movements of sexual activity. And the patient also has abnormal vaginal discharge, which is high sensitivity up to 75% of individuals. Vaginal bleeding, including increased or prolonged menstrual bleeding. Postcoital bleeding, which occurs in more than 30% of patients. Irritative voiding symptoms. Systemic signs of fever, malaise, nausea and vomiting. Symptoms usually occur early in the menstrual cycle or at the end of the menses, okay, because of low progesterone levels and thinning of the cervical mucosal barrier, okay. So on physical examination, you will feel there is a lower abdominal tenderness, cervical motion tenderness, uterino-adnexal tenderness. Basically, they'll come with lower abdominal tenderness, okay. If there is involuntary guarding or rebound tenderness, it means the patient has already developed peritonitis, okay. Luckily, most of us will think of appendicitis and we'll do an ultrasound or a CT for that people, right? Usually for young female, we try the best not to do a CT, okay, not to put them under any radiation. So usually we'll ask for a ultrasound. So the positive predictive value of these findings to indicate a PID depends upon in which area you're working, in which from which area the particular patient comes from, okay, the given clinical picture and the given environmental prevalence, okay. Adnexal tenderness has a sensitivity of 95%, right? A young female presenting to you with low abdominal pain, adnexal tenderness, and no other causes being found, they do an ultrasound abdomen, the appendix is completely normal, or the tube length, the fallopian tube is looking inflamed. All these things puts to the patient as PID, right? Mucopurulent cervicitis is very common. Okay, cervicitis very common. If there is no cervicitis, it means that you might think of other alternate diagnosis for this abdominal pain. Okay, such sensitive is that cervicitis. And again, in clinical features, apart from lower abdominal pain, understand patient can present with right upper abdominal pain as well. Okay, so this is one area where patient presents with right upper abdominal pain, but your diagnosis is PID. You got it? Because it's a PID which is causing inflammation which has spread through the peritoneum, through direct spread or through the lymphatics to the liver, causing this particular syndrome. Okay, so patient might come with right upper quadrant tenderness as well. Okay, especially if the patient have jaundice, it indicates perihepatic inflammation. Again, to point out, it's Fitz-Hugh-Curtis syndrome. Okay, be very confident about the syndrome. This is an exam question. Okay, it is usually an uncommon complication, and this also responds to standard antibiotic therapy for PID. You treat the PID, need not go for gallbladder surgery. Okay, since the patient has come with right upper abdominal tenderness, need not go for gallbladder surgery. It's basically a PID. You treat the PID, you control the infection, inflammation, then this particular syndrome will get controlled. Okay, so whenever you find a patient with Fitz-Hugh-Curtis syndrome, look for other signs of sexually transmitted diseases as well. Okay, so PID is primarily a disease of upper reproductive system. right? But understand, when you identify a patient with upper reproductive tract symptoms, you look for what is happening in the lower reproductive tract as well. Okay, look for other STDs, syphilis, herpes simplex, any ulcers present, or human papilloma virus, what's present in the lower genital tract as well. Okay. What is the differential diagnosis of PID? Cervicitis, ectopic pregnancy, endometriosis, ovarian cyst, ovarian torsion, spontaneous abortion, septic abortion, cholecystitis, a simple gastroenteritis, appendicitis, diverticulitis, pyelonephritis, and of course could be a renal colic as well. So diagnosis. So understand, no single history or no single physical examination or no single laboratory information can be very sensitive or specific for the disease. Okay, understand, any reproductive age group woman coming to you with an abdominal pain, always consider pregnancy in a childbearing age group. Okay, it is not okay to miss out a pregnancy, right? It's not okay that you miss out a diagnosis of pregnancy in a female who's coming with a lower abdominal pain. It could be an ectopic pregnancy or missed pregnancy or even a septic abortion, right? So with your history, clinical examination, or laboratory information, you will not be able to come to a conclusion of PID to 100%. Okay, even if you diagnose a PID, look whether the patient is pregnant. Look whether the patient is having an ectopic pregnancy. Okay. So next step is obtain a saline and potassium hydroxide treated with preparation of vaginal secretion to identify whether there is leukorrhea. There is more than one polymononuclear leukocyte per epithelial cells, basically WBC sort of. Trichomonas infection present or not, or test for bacterial vaginosis like clue cells, pH, and whiff test. Okay. What is whiff test? 10% of KOH is applied over this particular vaginal secretions. It will give you a order. Okay, that's called a whiff test, right? So in that particular sample of vaginal secretion, if there is increased white blood cells, it means that it is bacterial vaginosis along with cervicitis. Okay, bacterial vaginosis has clue cells. Okay, if there is clue cells plus polymononuclear cells, basically WBCs, then this is equal to bacterial vaginosis along with some itis, possibly cervicitis. Okay, so only clue cells, bacterial vaginosis. Clue cells with WBC cells, it's bacterial vaginosis plus cervicitis. Whenever you speak about cervicitis, then there's an inflammation associated with this, then it can go for ascending inflammation. That is indirect evidence that you're dealing with pelvic inflammatory disease. Okay, so now what is clue cells? See, this is how a normal smear looks like. From the cervical secretions, a normal smear look like. Okay, these are the cells, and some 1 or 2 lactobacillus will be here and there present. Okay, if there are too many bacillus, if there are too many bacteria attached to the cells, this is called as clue cells. Okay, you look that this is Gardnerella vaginalis. Okay, the vaginal epithelial clue cell coated with Gardnerella vaginalis. This is how the cell looks. Look here, like this. Can you see this? This is how it looks. Under the microscope, this is how it looks. See how densely this bacteria is affecting this particular epithelial cells. Okay, this is called clue cells, epithelial cells which is filled or attacked by massive bacteria. Okay, these are the clue cells. Can you see that? How densely they are affected? So this leukorrhea is sensitive, but it's not specific for upper tract infection. Okay, but if there is no leukorrhea, if there is no itis, if there is no inflammation, if there is no WBCs, absence of leukorrhea is definitely a negative predictor of PID. Understand this. Got it? If there is no itis, PID is pelvic inflammatory disease. If there is no inflammation, it's not PID. If there is no WBC, there is no inflammation, right? If there is no leukorrhea, it's a negative predictive value of PID. Understand this. Endocervical swab, you can send for culture and gram stain. This is a age-old technique. You need to do a gram stain. You need to think whether it's a gram positive, gram negative, it's rods or coccus or bacillus. There are numerous organisms. This is one way, the old way. Do the culture and wait for 5-6 days for it to grow, right? But nowadays, there is nucleic acid amplification test and DNA probes for this Neisseria gonorrhea and chlamydia. And also, recently in 2013, they have developed for trichomonas as well. Okay, so since we have this kind of latest test, nowadays less likely they are trusting on Gram-Stein culture. Even though they do Gram-Stein culture, they still go for this kind of nucleic acid amplification test and DNA probes. Okay, so if positive, the probability of PID increases. Okay, because these are the bugs which usually causes PID. And whenever you're handling a patient with PID, when you have suspicious PID, number one, make sure the patient is not pregnant. Okay, whether it's a normal pregnancy, tubal pregnancy, I mean ectopic pregnancy, ruptured pregnancy, or septic pregnancy. So pregnancy and associated complications has to be ruled for the first place. As far as PID is concerned. And second, you need to think whether it's really PID or any other associated differential diagnosis. Is it an appendicitis? Is it just a gastroenteritis? Is it a tubal ovarian cyst, or is it a torsion of the ovaries? So the differential diagnosis has to be thought of. Okay, so that also has to be handled. And third, the infection associated with it. Infection causing the PID and infection of the lower reproductive tract. Okay, infection causing the PID and infection of the lower tract. This lower tract infection can be bacterial, can be even viral, can be STD as well. You need to treat everything along with fourth. Very, very, very important. Treat the partner. Okay, so patients may have multiple STDs. So do a rapid plasma reagent test for syphilis, test for HIV, test for hepatitis as well. Okay, urine analysis can exclude a UTI. Okay, if there is no urinary pus cell, there is no bacteria present in the urine, that it is not UTI. But a positive urine analysis does not exclude PID. Okay, because any inflammatory process in contiguous pelvis can produce WBCs in the urine. So since because in urine you have pus cells, doesn't mean that you have UTI. That means that your patient has UTI. Okay, and of course we are dealing with the PID, so blood cultures do not aid in the diagnosis or treatment.